So, good afternoon, one and all present here. Thank you very much for sparing the valuable time and joining us for this scientific session. Before we start this session, let me introduce briefly Dr. Arun. Dr. Arun is DNB and DM Gastro. He is a consultant gastroenterologist, hepatologist, and interventional endoscopist from the Apollo Hospital, Maine, Chennai. Sir will be taking us through recent updates on the hepatobiliary disease management, and specifically if we talk about it is NASH management and role of newer molecule like obeticholic acid in the particular therapy. With this note, sir, I'll hand over the session to you.
Thank you, Tom, to give me a brief opportunity to be here to share some insights and focus what is happening in the field of non-alcoholic fatty liver disease. Thank you all the delegates who are being here, because in this tough afternoon, in your busy schedule, you are going to spend some time to analyze the concepts, what are the things which is going to happen in the management of non-alcoholic fatty liver disease, because it's one of the common spectrum nowadays to tackle. It's one of the difficult entity for most of the gastroenterologists, so that's for the hepatologists to diagnose and to tackle, because who are the patients going to land up with this kind of presentation? Because when you're going to look into the scenario, first, I don't want to take this discussion very complex because we are targeting the physicians also, but I would like to make this discussion very simple. The main thing, what are the population at risk? How are you going to recognize a patient who is going to land up in fatty liver? Once a patient is going to land up with evidence of fatty liver, how are you going to monitor those kind of patients? Once a patient is going to have evidence of fatty liver, how are you going to manage the patient? What is the diet and lifestyle modifications advice will you suggest? If at all, if you're going to do something with your drugs, which is least available in the market, what are the strategies you can apply for usage of that kind of drugs? And what are the patient deserve a further advances in the management of, for example, of liver transplant and other kinds? So these are all the brief area I would like to discuss with you all in the management of non-alcoholic fatty liver disease. So if you're going to look into the brief scenario, so what do you mean by this fatty liver disease? See, in case if your hepatocyte, if it is going to be contained for more than 5% of your fat, if it is going to accumulate in your hepatocyte, it's nothing but a fatty liver entity. Once a patient is going to land up with more than 5% of the fat accumulation, along with evidence of disease progression, nothing but a non-alcoholic steatohepatitis, and it will be leading to non-alcoholic fatty liver disease. So what does this? There are so many definitions out there. If you're going to look into the data which is available from AASLD, American Academic Society of Liver Disease, and also from your AASL guidelines, there are so many papers to quote the beneficial role. I mean, the definition for this non-alcoholic fatty liver disease. But the main thing, if your hepatocyte, if it is going to contain more than 5% of fat, and next to that, in case if you're going to land up by, if you're going to do any advanced imaging modality, for example, if you're going for MRS, nothing but magnetic resonance spectroscopy. In case if you're going to use that, if your hepatocyte, if it is going to show, if your liver enhancing, if it is going to be more than 5.6%, if it is going to be a spectroscopy enhancing focus, if it is going to be there, that shows evidence of a non-alcoholic fatty liver disease progression. See, so what is this problem? See, there are multiple etiology for you to develop a fatty liver. You can develop because of your infections. You can develop because of your fat, excess obesity, diabetes. There are so many predisposing factors. And next to that, if you're going to be alcoholic, there is high possibility for you, because alcoholic population, more than 80 to 90% of the 90 to 100% of the alcoholic population, there is high possibility for them to land up with fatty liver. Once a patient is going to land up with fatty liver, the diet, lifestyle modification, what I'm going to discuss with you all, if you're going to do properly, definitely you can able to improve your scenario. But as the disease progresses, you are going to establish in a condition in which you are going to land up with the disease, even nothing but non-alcoholic steatohepatitis. From this non-alcoholic steatohepatitis, you are going to land up in fibrosis, you are going to land up in cirrhosis, you are going to land up in carcinoma, which is nothing but hepatocellular cancer. So these are all the areas you need to look into that. These are all the areas you should be alert when you're going to manage a patient with fatty liver. And you might be wondering that. So who are the patient who's going to develop fatty liver? There are so many events, even if the patient's so lean, there is entirely what is called as lean NASH, which is most of the time, which is being well followed in India also. The definitions have been well recorded right now in India also, if you're going to look into this lean NASH and the other scenarios. But non-alcoholic fatty liver disease, if you want to discuss, the most important triggering factors to be avoided, the precipitating factors should be avoided. You need to take care of the diet and lifestyle modification, all those things. If you want to discuss about this NAFLD, the most common entity, because there is not, it's a multi-event disorder. There are multiple disorders which will be predisposing. For example, if you're obese, if you're type 2 diabetes, if you're going to have rickets, if you're going to have vitamin D deficiency, in case if you're going to land up with obstructive sleep apnea, there are predisposing multiple events for you to develop this kind of presentation. But most of the time, once the patient is going to diagnose with non-alcoholic fatty liver disease, don't think that the mortality is only because of the liver-related problem. Most of the time, the mortality is mainly because of your cardiovascular illness, because of your type 2 diabetes, uncontrolled diabetes, obesity, dyslipidemia, and your metabolic syndrome. If it is going to get super vain, that is the area where you're going to get shut down. And at that point of juncture, your worsening of events is going to take on, and thereby you're going to succumb because of that kind of illness. So most common cause of morbidity as well as mortality in the background of NAFLD is mainly because of your cardiovascular disease that has to be strongly addressed when you're going to manage a patient with NAFLD. This is briefly about the spectrum. As I discussed with you all in my multiple previous presentations, if you're going to look into my paper, what are the things, if you can browse into my all previous videos in Chandra Gastro Liver Clinic and Endoscopic Center, which has been previously available in Facebook and YouTube. If you're going to look into that, I'll be discussing about this area multiple times. See, the normal liver will be going for a steatohepatitis segment, and from there you can go for a non-alcoholic steatohepatitis, and from there you can land up with a cirrhotic background. So once a patient is going for cirrhotic background, there is high possibility for you to land up with hepatocellular cancer. Why? Because how long it is going to take, how the disease is going to get progress, that's an area you need to address promptly if you want to manage a patient with this kind of scenario. See, this steatosis, if the patient is most, even 90 to 100, 80 to 90% of the population is going to land up with this, but how is it going to get progress to this even non-alcoholic steatohepatitis by your histological changes, by your clinical presentation, and by your lab parameters. By all these events, you're going to determine this non-alcoholic steatohepatitis, but it may take some years, around 5 to 7 years or 7 to 8 years, around 15 to 20% or 20 to 25% of the population from this scenario you can go for this scenario. But from this to this, around 8, it will take another few more years from this to this to be taking on. And from cirrhosis to hepatocellular cancer, the possibility in the background of non-alcoholic fatty liver disease will be around approximately 1 to 5% of the population can land up with this kind of cirrhotic and hepatocellular cancer. So in India, the data, see, always don't think if you're going to consume alcohol, you're going to land up with this kind of liver. No, now the data is almost similar in par with the westernized countries because of your lifestyle, a sedentary habit, non-working IT professions who are not going to be very active in the lifestyle because of your depression, your dyslipidemia, worsening of events, the vicious cycle, if it is going to set in, thereby you're going to land up with this kind of fatty liver disease, which will be predisposing to multiple complications in your life as the day progresses. So how to halt the disease, how to control, that's the most important area for me to address right now with you all. But the other spectrum, in India, if you're going to look, the global prevalence is almost going to touch almost around 25% of the population of NAFLD is going to be estimated. But in India, if you're going to take the data, in the northern part, almost around 50% of the population who are having evidence of liver disease, in the background of estimated non-alcoholic fatty liver disease population, almost around 50% will be predominantly from northern part of India, and almost 20 to 30% will be from southern India. That was being taken from the recent paper, and around 15 to 16% from the western as well as in eastern India. So why I would like to point, the southern India also is going to be ranked 2 if you want to look into the data for non-alcoholic fatty liver disease. So NASH is estimated to be prevalent at around 59% of the population among them who are going to land with non-alcoholic fatty liver disease. So 16 to 30% of the general population in India, nearly 120 million as NAFLD, and among them nearly 31 are diagnosed with this kind of NASH. Why I would like to point out, because easy to recognize a clinical presentation of alcohol and the patient is going to land up with liver disease. But it's difficult for you to pick up the finding once a patient, how the patient is going to progress because of your insulin resistance, because of your obesity, because of your dyslipidemia. These are all not being visible. So that's what the tip of the iceberg, what you're going to see right now is nothing but a non-alcoholic fatty liver disease. So most of the time, the diagnosis will not be done properly. And always, once a patient is obese, don't think that the etiology is mainly because of fatty liver disease. It could be because of multiple events. Remember only one point, a non-alcoholic fatty liver disease is mainly a diagnosis of exclusion. Don't think that if the patient is having this kind of presentation, so immediately diagnose, label the patient. No, nothing like that. There are so many pointers, your fibrotic scoring, your clinical scoring, your lab parameters, and there are so many histological scoring are there to analyze this non-alcoholic fatty liver disease. But always is a diagnosis of exclusion. You need to look for the common etiological triggers like alcohol, which is well available in India. And apart from that, you need to look for infectious triggers like your BC, and you need to look for multiple metabolic problems and metabolic liver disease and the various toxins which is being there, all the predisposing even for your liver disease. You need to rule out, you need to work up for that kind of first an autoimmune metabolic. So many etiological factors are there. And after excluding all the possibilities, only we need to diagnose this non-alcoholic fatty liver disease as a diagnosis of exclusion. And don't jump into the conclusion once a patient is going to present with this kind of event. So you need to work up this kind of patient, whether the patient is going to land up with this kind of events are there or not. And next to that, basic risk factors, your sedentary lifestyle, morbid obesity. If your BMI, if it is going to be more than 30, high possibility for you to worsen, you get worsening of this kind of events, insulin resistance, type 2 diabetes, dyslipidemia, your metabolic syndrome, your hypertension, all those things, and based upon your liver enzyme factors also, and based upon your histological factors also, there are so many things to ask for you to take care of this risk factors for non-alcoholic fatty liver disease and NASH. Briefly about the pathophysiology, it's very complex area for us to understand, but I would like to make this kind of scenario very simple, because you know about the liver injury. Once a liver injury is going to get set in, how the event is going to get progress. There is single hit hypothesis, there is double hit hypothesis, and there is triplet hypothesis. Now the concept has gone up to a multi-hit hypothesis. There are multiple triggers, multiple mechanisms, which is going to involve in the pathophysiology of NAFLD. So what is the primary thing? That's mainly because of your insulin resistance. Once the insulin resistance, if it is going to get happen, what is going to be there? The anti-lipolytic action of your insulin, it is going to come down. Once the anti-lipolytic action of insulin, if it is going to come down, the levels of your lipids, the levels of your TGL, if it is going to get accumulated, and followed by, there might be evidence of de novo lipogenesis, which is going to get activated, and that shows evidence of your hepatocyte injury, your involvement of cytokines, your involvement of mitochondrial toxicity, and that shows evidence of progression of worsening of events in the background of non-alcoholic fatty liver disease. So if you want to look into that, your dyslipidemia, your diet, even don't think that if you're going to land up with high fatty diet will be predisposing to this non-alcoholic fatty liver. Not like that. Even if your diet contains high carbohydrate load, so avoid your carbohydrates, avoid your diet, follow a Mediterranean diet pattern, and high fructose or glucose diet, your sedentary lifestyle, and your free fatty acids, derivatives, and your cholesterol, your metabolic products, all those things, what is going to predispose, followed by first the event is going to set up in steatosis, and slowly the lobular inflammation and NASH and fibrotic changes and cirrhosis and hepatocellular cancer will be checking on. So in all the inflammatory cascade, there are a huge list of toxicity, the apoptosis, your necroptic activities, your autophagy, all those things, your mitochondrial toxicity, your cell damage, your oxidative stress, your endoplasmic reticulum stress pathway, followed by your DNA damage, which is going to get set in. All these mechanics will be predisposing to release of multiple cascades of your inflammatory pathways. The inflammatory cascade, like your cytokines, the inflammatory cascade, like your interleukins, your PRR activation, and followed by multiple inflammasomes, which is going to get triggered out, and there will be evidence of your CD8 as well as T cell injury, which will be releasing your activated macrophages, will be predisposing to this kind of event. So once this kind of events is going to get targeted, the continuous multi-hit hypothesis is going to get take on, followed by your genetic injury, your palatin peptide. There are so many other pathways for us to take on, but since lack of time, I don't want to progress the entire pathophysiology, but briefly, there are multiple triggering modalities there for you to analyze if you want to target this multi-hit hypothesis. So briefly, if you're going to see, not only because of your lifestyle, one is because of your gut dysbiosis. See, now the gut dysbiosis is going to consider as a separate entity, because once a gut is going to get dysbiosed, your symbiosis of your gut, if it is going to get lost of, and followed by what is going to happen, you are going to develop a multi-modalities of complications. The bacterial activation factors is going to get in there, and the PAMP and DAMP is going to get released. That's nothing but pathogen associated molecular pattern, as well as your damage associated molecular pattern. All those things is going to get activated, followed by you may land up with multi-modality of complications. That's why the hepatocyte injury by all the cytokines, DAMs, and all those things is going to get involved, and thereby you're going to lead for this, what is called as hepatocyte stellate cells, which is going to, that's the most important area, would be getting infected by the inflammatory cascade. That will be leading due to fibrosis and inflammation. All those things is going to set in because of this multi-modality trigger. The environmental factors, your dysbiosis, your metabolic factors like your insulin resistance, predisposing to your all the high carbohydrate diet, your de novo lipogenesis, your accumulation of free fatty acids, which will be predisposing to your steatosis, your genetic factors, your endoplasmic reticulum, as well as your mitochondrial stress. All those things are there to discuss. And remember that your adiponectin level, if it is going to come down, your leptin as well as your resistin, if the levels are going to go high, the possibility of the liver and the lipogenic activities, if it is going to get worse now, followed by you may land up with this kind of NAFLD and other problems to take on. So briefly, based upon your dietary fat as well as your dietary sugars, so your chylomicron activation, your TGL accumulation in the adipose tissue, so which will be predisposing to release of fatty acids into the blood, followed by your free fatty acid mediated injury, TGL accumulation, lipotoxic lipids like your diacylglycerol, multiple areas are there, and your hepatocellular injury, NASH, fibrosis, and HCC. All those things is going to get take on mainly by this lipotoxic liver injury. That's a substrate model. That's what is called as newer guidelines. What have been mentioned in that, based upon your BMC medicine latest paper 2017, what they've been quoted based upon your SOLI model. That's nothing but substrate overload lipotoxic injury model of NASH pathogenesis. So once acetyl-CoA substrate from your dietary sugars, the steroid response element binding protein activation, there are more of theoretical discussion, but briefly, your insulin resistance, your lipid activation, de novo lipogenesis, TGL accumulation, and followed by your inflammatory cascade, which is going to get take on because of your all the apoptotic injury, mitochondrial and ER stress, which will be predisposing to this NAFLD, if you want to remember this briefly. Directly, we are going to into management options. When you're going to look into that, there are so many modalities to diagnose. You can diagnose by clinical picture, you can diagnose by fibroscan, you can diagnose by multiple scoring system. NASH scoring systems are there. That's nothing but NFS scoring system, and there are enhanced liver fibrosis, BARD. So many scoring systems are there for you to look for this non-alcoholic fatty liver disease. That's why it's even one more toughest entity for the gastroenterologist to diagnose, to tackle, to counsel, to manage, to dissolve the patient for liver transplant. And management goals, if you want to look into that, the main primary modality, you need to halt the progression. You need to improve the insulin resistance, control the lipid accumulation. So how are you going to check around this? Control obesity, dyslipidemia, hypertension. So diet modification. What sort of diet you're going to get advice? The lifestyle interventions and your physical activity. Basically, if you want to consider your physical activity, make sure you need to work up at least 4 to 5 hours in a week. That's the most important thing. And minimum of 30 to 45 minutes in a day. You should do this kind of activities. And what sort of exercise? Aerobic exercise. That's one of the most. See, exercise, I will tell you very briefly. You don't think that if you walk, you're going to reduce your weight. No, you need to target your heart rate. Your heart rate, suppose in the age group of 30, if you're, for example, I'm telling you, and you need to target a heart rate of 220 minus your age. For example, that will be coming around 190. And when you're doing exercise, you need to target this 60 to 70% of your maximal heart rate. So calculate your maximal heart rate as per your age, and followed by, you need to target your heart rate when you're going to do some exercise. 60 to 70% of the heart rate has to be there. Once you are going to establish that, there is high possibility when you're going to do 3 to 5 hours, minimum 5 hours of activity, definitely your NAFLD and other symptoms, your steatohepatitis scoring system will be there, and multiple graphs are there, 3% improvement, 5% improvement, 7%. In various presentations I haven't presented, but since lack of time, I don't want to go into the much of these details, but lifestyle intervention, dietary and lifestyle modification is one of the most important things to be addressed strongly. And diet, what I've been discussed, like your low carbohydrate as well as your low lipid containing diet has to be enhanced when you want to manage a patient with this kind of non-alcoholic fatty liver disease. Directly into the drug line of management, there are so many drugs, anti-diabetic profiles, your OHs, and all those drugs are being tried based upon your Prevalence trial. High dose vitamin E can be tried, but there are some possibility for this vitamin E to show. But our main area, the newer molecule, even sorraglatazole can be tried, the newer molecule like obeticholic acid. What is this obeticholic acid? Nothing but Farnesoid X receptor agonist can be considered in the management of your non-alcoholic fatty liver disease once a patient is going to land up with fatty liver. So based upon your metformin, your pioglitazone, so many trials are there. There might be some evidence in the management, but AASLD doesn't show much of improvement for NASH with metformin, but pioglitazone only in biopsy proven non-alcoholic steatohepatitis, not for fatty liver patient, that shows evidence of response in pioglitazone. And you need to target your oxidative stress. This is based upon your insulin resistance. How are you going to target your oxidative stress? Mainly by vitamin E. Vitamin E strongly can be considered, but high doses, there are some papers to quote that you might land up with prostatic cancer. So you need to be cautious when you're going to use high dose of vitamin E. But in my experience in Apollo, frequently I'll be using vitamin E, considering you need to target, how are you going to manage, how are you going to see the scenario. But definitely that shows a reasonable improvement if you're going to use vitamin E as a strong antioxidant based upon the various trials, for example, which is going to be available. If you notice that your Prevalence trial, if you're going to see that your non-alcoholic, your NASH score, definitely it is going to come down by more than 2 points, more than 2 points if the patient is not going to have any fibrotic background. That shows evidence of improvement. So vitamin E can be considered, but if you're going to look into this AASLD guidelines, which has been taken from 2018 paper, so vitamin E, once the patient is going to be having evidence of cirrhosis, the role of vitamin E is definitely a questionable issue, not much of response, but without diabetes, there might be strong consideration in the background of non-alcoholic fatty liver disease management. But pioglitazone, that is not shows much of evidence in the background of cirrhosis, or with or without diabetes in the background of NASH, you can consider pioglitazone. There are so many other drugs like liraglutide and metformin, newer molecules like Sensorivag, your pan-caspase inhibitor, huge list of drugs. It's not the area for us to take on the discussion, but briefly about vitamin E, it's at around 800 international units per day you can consider, but that shows some paper to look for hemorrhagic stroke, also to look for your prostatic malignancy to get increased. And when you're going to use pioglitazone, only thing always you need to monitor for the cardiovascular, your volume overload status because of edema and other things can be supervened, and bladder cancer risk. Some patients are being come case reports are being there. So use of these agents still cautious when you're going to look into that. And what is the gap in the management of NASH? Because you are going to look into that, we need to target the dyslipidemia, we need to control the cardiovascular associated morbidity, and the NAFLD pathophysiology is such a complex phenomena for us to understood. So not one single molecule has stand tested right now to have a strong beneficial role in the management of non-alcoholic fatty liver disease. So the overall burden as day progresses, our routine lifestyle, because of the sedentary activities, the disease burden is going high, and the molecular target one going to manage, it's coming down. That's why most of the patients in the background of NAFLD nowadays is going for the advanced liver pathology like cirrhosis, advanced pathology like your hepatocellular cancer. We have been seeing more and more patients nowadays, even Apollo, I'm seeing multiple patients who are coming from Northern India. So with this kind of background, what I would like to say, we need to look for this kind of scenario when you're going to manage a patient. So there are no single approved therapy for the management of NASH based upon your FDA. And apart from that, multiple trials with multiple events. So this is the paper which has been taken from the recent AASLD guidelines. So once a patient is going to have normal liver, your steatosis, your steatohepatitis, what are the molecules? What are the so many list of drugs? Briefly remember the area where you're going to use obeticholic acids, mainly your target, your lipotoxicity and your oxidative stress. So it's going to act in a receptor pathway, FXR pathway. It is going to act as an agonist. You can use at the rate of 5 milligrams. You can use at the rate of 10 milligrams. You can use at the rate of 25 milligrams. I will based upon some adverse events is there, but you can target. There are so many other list of molecules like your sensitive, rock and your selonsertib, your galactine, your pioglitazone, so many other list of molecules. That's not the area for us to take on the discussion. The main focus is obeticholic acid, the role in NAFLD. So you need to target your FXR, Farnesoid X receptor agonist, because what you're going to do that once you're going to go bind with your FXR, the lipophilic bile acids, it's going to promote your insulin sensitivity, as well as it's going to decrease your gluconeogenesis, and it's going to come down, it's going to bring down halt of your triglyceride. So what is going to happen? These beneficial effects are mediated by decrease your hepatic lipid synthesis, as well as your enhanced clearance of your VLDL. So the main thing, we need to target the FXR activation, increases the expression of your scavenger receptors, which accelerates your cholesterol transport by increasing the clearance of your lipoprotein. So main thing, how does it going to happen? How does it going to create impact? If you're going to look into this, this is nothing but a 6-ethyl quinodeoxycholic acid, which is a synthetic derivative of your natural bile acid, nothing but CDCA. It's a quinodeoxycholic acid. So it's a selective and potential FXR agonist, almost at a rate of around 100%, 100-fold greater FXR activity than your CDCA. So once it's going to have 100% greater potential, that shows evidence that it is going to bring a halt for it is going to improve insulin sensitivity. It is going to modulate your lipid metabolism. It's going to free your, lowers your free fatty acid synthesis in your muscles and liver. And thereby it's going to protect against your bile acid induced cytotoxicity, bile acid mediated lipotoxicity. All those damages is going to get prevented because when you're going to use FXR agonists strongly in the management. So the less lipophilic bile acid UDCA binds negligibly to FXR, and randomized trial, it did not show efficacy in non-alcoholic. So when you're bringing, there are multiple questions for us. What's the role of UDCA? But isolated, there are some papers spotted some minimal beneficial role, but maximum papers which are being derivating no much of role for UDCA in the management of non-alcoholic fatty liver, and you need to consider either sorroglitazone, or you're going to use vitamin E, or you need to add on with the newer therapies like your obeticholic acid in the armamentarium of management of NAFLD. So in the background of type 2 diabetes and suspected NAFLD, obeticholic acid shows evidence of your improvement of insulin sensitivity and reduces your enzyme levels significantly. So if you're going to look into that, your AST and ALT, your enzyme factors strongly to be addressed, your bilirubin has to be addressed. So if the patient is going to be a non-alcoholic steatohepatitis, because it's a clinical scenario, it's a clinical presentation, you'll be having evidence of CLE, you'll be having evidence of acute liver injury, you may be having evidence of splenomegaly, you may be toxic if the patient is going to land up with NASH. So NASH is one complex entity. You need to hospitalize, you need to manage the patient. So strongly you need to consider in the management protocol. And multiple effects are mediated activities of OCA have been proven preclinically, like what have been discussed. So also it is going to have an anti-inflammatory effect. Also, it is going to decrease your activation of your hepatic stellate cells. That's how the mechanism of action of your obeticholic acid is going to take on, followed by it's going to prevent your liver fibrosis also. So there are multiple clinical data, there are multiple papers. One is by FLINT trial, and if you're going to look into this obeticholic acid, the proven beneficial role is only for one major condition, nothing but your primary biliary cholangitis. It's nothing but your high level of ALP will be there. It's an autoimmune pathology, self-mediated destruction of your of your own cholangiocytes. What's going to happen at the bile ducts is going to get destructed by, followed by, in this kind of scenario, you can combine high dose of EODCA along with obeticholic acid. There are multiple papers to report the beneficial role, but even in the background of non-alcoholic fatty liver disease, as the trials are progressing, and that might be having some beneficial role when you're going to use this obeticholic acid in the armamentarium of your management protocol. And in this study, what they've been used, see, if you're going to use at the rate of around 25 milligrams for a duration of 72 weeks, it shows your NAFLD scoring by at least 2 points without worsening of fibrosis. There might be having evidence of improvement. So you can consider that this FLINT trial, what I've been mentioning, that it's going to target, it's going to term in in the background of NASH. What is going to happen? As I discussed with you all, your NASH scoring will be improved more than 2 points and with no worsening of your fibrosis. So obeticholic acid is usually well tolerated. Adverse events frequently reported are pruritus, but pruritus can be there. Once a patient is going to land up with cholestatic pathology, always you should remember that your pale stool, your pruritus, your characteristic presentation will be there. But most of the time, even in the background, if you're going to use obeticholic acid, that shows evidence of worsening of your pruritus might be there based upon the multiple study done in ILBS. So what we can do that, you can reduce the dosage regimen at a reduced dose. Only pruritus significant will be when you're going to use at the rate of around 25 milligrams. But when you're going to use at a reduced dose, like around 10 milligrams, the significant pruritic effect will definitely come down. That's definitely can be well ignored if you're going to manage your non-alcoholic fatty liver disease. So it improves the histological features of your NASH, but its long-term benefits and safety need further clarification, and we need more papers to look into that. This is another important trial being proven, that your REGENRATE trial, a phase 3 international randomized placebo-controlled study to evaluate the efficacy of your obeticholic acid in the treatment of NASH. So in this study, around 1968 population have been taken in the background of your NASH with the activity score of at least 4 and your fibrotic score of almost around F2, F3. In this background, you're going to subject the patient with either 10 milligram or 25 milligram of obeticholic acid, and you're going to look into your improvement of your fibrotic scoring, and also you need to show the evidence of resolution of NASH. So what they've been looked into this REGENRATE trial, it shows your fibrosis being significantly improved with the ability. There are so many criteria. You need to look for hepatocellular, hepatocyte injury, your ballooning degeneration, your histological proven factors, all those things to be measured if you want to look into that. That's a separate area for us to discuss. But briefly, I'm telling you, if you want to look into this, no worsening of NASH, defined by no worsening of hepatocellular ballooning or lobular inflammation or steatosis. That shows a significant improvement in the if the patients are in fibrotic scoring in the background of non-alcoholic steatohepatitis, if you're going to manage with obeticholic acid as per your REGENRATE trial. And NASH resolution defined as overall pathologist assessment of no steatohepatitis and hepatocellular ballooning and lobular inflammation. If you're going to look into this paper, see, once the patient is going to subject almost at a dose of around 10 milligrams, the resolution symptom with no worsening of fibrosis, almost in the dose of 10 milligrams, it definitely will be high, and rather than when you're going at the rate when comparing to your placebo. So that shows some significant beneficial role is there. And based upon that, the conclusion, what they're going to derive is a significantly higher proportion of patients who are receiving obeticholic acid at a dose of around 25 milligrams compared with placebo shows improvement in NASH by at least 2 points with no worsening of fibrosis and no disease progression. and no worsening of other events in the management protocol. So either you can consider 10 milligrams or 25 milligrams, but my advice in my experience, always to start at a lower dose, titrate at a higher dose regimen, and you can consider for a period of 12 months of duration if you want to manage a patient with non-alcoholic fatty liver disease. And there are people to look for around 6 to 12 months of duration, but you need to manage considerably. You need to explain the advice, even serial monitoring under the supervision of a gastroenterologist is the most important thing when you're going to use obeticholic acid. Nowadays, we are seeing many patients, irrational usage of obeticholic acid by many physicians. That should be strongly avoided when you're going to manage a patient with this NAFLD problems. So the safety and efficacy is one questionable thing, still need to be addressed well in multiple papers to be quoted. And pruritus, as I discussed, at the higher dose, the risk of pruritus is slightly high, but the early increase in your LDL cholesterol being absorbed, but as the day progresses over the duration, the level of titration definitely is going to come down. That's not a very significant problem. So to conclude the regenerated trial, so significant improvement of fibrosis will be there when you're going to use 25 milligrams. Significant histological improvement will be there. And this study is ongoing to assess your clinical outcomes. So based upon your control trial, wanted to mention that a randomized phase 2, when you're going to combine your statin in the background of your dyslipidemia along with your obeticholic acid, what they've been assessed in this, so your statins as well as your OCA, when concurrent daily atorvastatin at a dose of around 10 milligrams was initiated at week 4 with subsequent titration, either you're going to receive 5 or 10 or 25 milligram of OCA during a follow-up of almost around 16 weeks. So it shows that the obeticholic acid induced increase in LDL cholesterol in patients with NASH were mitigated with atorvastatin. The combination of OCA and atorvastatin was reasonably safe as well as well tolerated. So that's what you can combine your anti-lipid lowering agents along with your obeticholic acid in the management of your non-alcoholic fatty liver disease. And before concluding, so remember that NAFLD is very complex entity to recognize, to manage, to avoid, to recognize early complications, to be in serial follow-up, always is a diagnosis of exclusion, counsel the patient, diet and lifestyle modifications, the most important, see the clinical pointers, look for evidence of progression, look for evidence of chronic liver disease, for example, head-to-foot assessment, see for jaundice, PANA, erythema, the evidence of CLD, spinal nevus, the gynecomastia, so many other things to look for the progression, look for evidence of NASH, which means your platelet drop, your counts are going high, your toxic appearance, your massive splenomegaly, and your toxicity, all those pointers to address your NASH, as well as your histological scoring and fibrotic indices, all those pointers to be considered, your endoscopic severity assessment, and based upon the patient is going to land up with chronic liver disease, is there or not, control the patient in the background of fatty liver, and don't avoid the patient to progress for NASH and other complications. But still now, obeticholic acid can be tried in the background of management of a non-alcoholic steatohepatitis, but how far it is going to be successful in the management of isolated fatty liver is still a questionable issue. But as the day progresses on, we can see more papers to document with that. So safely and considering monitoring under the guidance of gastroenterologist protocol, what we mentioned, you can consider obeticholic acid in the management of non-alcoholic fatty liver disease. With this, I would like to rest my presentation, and I'm happy to take up your questions if anything is there to take on. Thanking you all for patient listening. Any questions?
Thank you very much, sir, for your detailed view about this topic and very nice presentation. Now, participants may ask any question.
I have seen Dr. Pandita, sir. Thank you, sir. Dr. Pandita is a co-consultant along with us in Main Apollo. And
If we have any question, we can ask. Sir will be there to answer.
It's time for us to go break your lunch. That's why I think everyone is busy with the questions.
Right, sir. Sir, once again, I would like to thank you very much for your valuable time and your views about this topic. And once again, thank you to all the participants for sparing their valuable time from their busy schedule and joining us for this scientific session. We will be always there. Torrent will be always there to provide the scientific platform. That's it from our side. Thank you very much.
Thank you, sir. Thank you. Thank you for all the delegates for being here. Thank you, Torrent.
Thank you, Arun sir. Thank you, Arun sir, and all doctors, respected doctors. Thank you.
Thank you. Thank you. Thank you. Thank you.